Yeah, welcome to this second part in the series of lectures in periodontology. Just to do a very quick uh, preview of the lecture notes, PowerPoint notes that you already have. And looking at periodontal inflammation, we are talking about things we already know: gingivitis, periodontitis, looking at pockets and related matters. Now, gingivitis. We know already it is associated with plaque. It is non-specific and it's a form of polymicrobial infection. The predisposing factors are there: poor hygiene, and the rest of it as indicated. Could be classified based on cause and duration. So it could be either chronic, acute, or subacute. The other details are there in the slide. Gingivitis will present changes in color of the gingiva, and with changes in size and shape, changes in consistency, texture, and then bleeding. The bleeding is probably the commonest clinical feature that you find. So healthy gums don't bleed. But once there's gingivitis, gingival inflammation, you are likely to have bleeding. Well, the next one here is just for you to contrast and see and look at those features. And what you see on the left side is showing, on the first slide there is the healthy gingiva. The slide following reflects gingival inflammation, where you have all the features there, the evidence of plaque accumulation, the redness around the upper right lateral, and then if you look at the upper left canine premolar region and the lower left premolar area also, lateral incisor area also, you find the redness. Now if you look at towards the right, the pictures on the right, these are just showing you variants of normal. All the pictures there, the three pictures there to the right are normal, depending on the level of pigmentation in that patient. Related to shape and size, you can see that the knife edge normally will become blunted with gingivitis. The firm, resilient, stippled appearance will become soft, friable, and smooth in the next slide. And then, talking about gingival crevicular fluid, it is now currently regarded as an exudate, an inflammatory exudate. Initially, people thought it was actually a physiologic transudate, but that view is no longer held. We now believe it is an inflammatory exudate, and it is increased by a number of things that you can see there: female sex hormones, brushing, chewing while you are eating, and the rest of them. There are certain histopathological correlates of these clinical features. Like the redness will be an indication of increased vascularization. Bleeding occurs as a result of increased vascularity and thinned epithelium. The flaccidity is as a result of atrophied epithelium and edema. And then the bluish red will be as a result of stagnation. And then you see the stages in gingivitis. What the takeaway here is to know that there are certain things that happen before you even start seeing the color changes. Certain things already are happening in the background, like the vascular dilatation. You might not see any evidence of that clinically, like the infiltration of neutrophils. And the main cells being involved in this stage being the polymorphonuclear neutrophils. That is happening within 2 to 4 days. And then by the time you start having lymphocytes coming in, and the erythema and bleeding occurring, bleeding on probing, you are beginning to get to the chronic stage, which normally will take place around 4 to 7 days. So it's not immediately somebody starts brushing, and you might notice those. But it tells you that by the time you're seeing bleeding on probing, a number of things have occurred. There's been the dilatation, there's been some vasculitis, there's been a vascular proliferation, and lymphocytes now being predominant cells compared with the acute stage in which we held neutrophils. And then we have more of increased collagen loss around infiltrates. So the first things you are noticing there, the erythema, the bleeding on probing, are actually later stages in gingivitis. But when you have plasma cells, you are beginning to go into a more chronic stage. You still remember, you're going for neutrophils, acute, and by the time you are going to lymphocytes and plasma cells, that occurs in the more chronic stage. So this is the same kind of thing that you have with gingivitis. So gingivitis could be looked at in terms of the clinical distribution, could be localized, generalized, marginal, papillary, or diffuse. Now, when we say localized, we are talking about the number of sites involved. Once it is 30% and above, generally we say it is now generalized. Less than 30% is considered localized. And then you see marginal gingivitis there with the exclamation mark in red. We are careful with making a diagnosis of marginal gingivitis, because when you say marginal gingivitis, you should further investigate. It's not enough to just say marginal gingivitis. When people say chronic marginal gingivitis, trying to say they didn't see anything clinically per se. But this is a bit misleading. When you say marginal gingivitis, there is frank gingivitis redness limited to the gingival margin. It calls for further investigation, because this might not be bacterial related. It might be related to fungi. You might be dealing with linear gingival erythema. So when you say marginal gingivitis, it calls for further investigation. But even before that, then for such a patient, the first thing you should do is ask them to brush properly with proper plaque control. If it is just plaque induced, it should resolve. But if it does not resolve, and you need to start adding chemical plaque control before it goes off, you might be dealing with marginal gingivitis, which might actually be a form of linear gingival erythema, which is associated with immunosuppression. Note that I didn't say HIV, but any form of immunosuppression could be associated with this, including HIV. It could be papillary. It means it could be limited to the papillae, or affecting the papilla most. There are acute conditions, as indicated there, pericoronitis, desquamative gingivitis, and the rest of them. There's the acute hepatic gingivostomatitis, occurring more in children. The erythema, the vesicles, the pain, and the fact that it's a viral infection and that it is self-limiting. This is common in children. At times, the child has been given several bouts of malaria medication, and then the fever doesn't resolve, and it might be at the last stage before they remember to check them out. So let's not forget this. Pericoronitis, this is quite common. Well, one thing that we need to take away from here is that it's not all cases of pericoronitis that will require antibiotics. You only give antibiotics when there is evidence of systemic involvement. That will include fever and lymphadenopathy. So when there's no fever, there's no lymphadenopathy, your local debris flushing under the gingival flap there with warm saline, those will help. And then all you need to do at this stage is relieve pain. You might even give anti-inflammatory medication at this stage. But antibiotics, no, not at this stage, except when there's evidence of systemic involvement, evidenced by fever and enlarged painful lymph nodes. And then abscesses Could be periodontal or gingival. Very simple. When it is gingival, there's no pocket associated with abscess. But as a periodontal abscess, there's a pocket associated. Now, for acute periodontal abscess, note here that foreign body impaction, a furcation lesion, or a lateral perforation during root canal therapy, all this could lead to an acute periodontal abscess. Whereas for a gingival abscess, this is normally just limited to the marginal gingiva or papillary gingiva, as already indicated. There are certain differentials for these gingival abscesses or periodontal abscess. Now, if it is located near the root apex, you might actually be thinking about a periapical abscess or periodontal abscess, but you have to check for the vitality of the tooth. Normally, the non-vital will be for the periapical abscess, whereas a periodontal abscess, the tooth should be vital. Sensitivity to hot and cold is more with the periapical abscess because of the pulpal involvement, right? And then the one of the periapical abscess, usually there will be no signs or symptoms of periodontal diseases. And then periapical radiolucency, of course, will let you know that this is likely to be a periapical abscess rather than a periodontal abscess in which you might have horizontal bone loss. Other differentials will include perioendo lesion or endoperio, cracked tooth, and then root fracture. Well, antiseptic solutions will help in treatment. Foreign body removal, just by simply doing your root planing, will help. Drainage through the pocket, and the rest of it as indicated there. Again, antibiotics will be needed if and only if there are systemic signs of systemic involvement, as previously mentioned, or when there's evidence of poor prognosis. The things that will indicate poor prognosis might be horizontal mobility more than 1 mm, class 1 to 3 furcation lesions, deep pockets greater than 8 mm, and then poor response to treatment. In such cases, obviously, you need to support the patient with antibiotics. But outside those, just your regular treatment should do. Desquamative gingivitis, this is an interesting one. The desquamation of the gingival epithelium is normally associated with these vesiculobulous lesions, like the pemphigoid, lichen planus, erythema multiforme. These are often associated with these often have desquamative gingivitis associated with them. There's plenty of redness, and then you should note here that the marginal gingiva usually is spared, and is often an autoimmune disorder. That's the picture there showing desquamative gingivitis. Note that the marginal gingivae are spared. Right? Now, we go down to periodontitis. Periodontitis refers to the inflammation of the supporting apparatus of the teeth. It's a destructive change that leads to bone and periodontal attachment loss. It could also be regarded as a family of related diseases. What we are saying here is that some authors, like Eckstein, believe that periodontitis is not just a singular thing. It might actually be a family of related diseases that we are just thinking is a single entity. Now, the etiology of periodontitis is bacterial, because there are many microorganisms that initiate the progress. These organisms, when they interact with the host, they can cause direct and indirect damage. The direct damage occurring through direct tissue destruction, or indirect damage by modulating host response. The indirect damage at times is even worse. I know there are different levels of this modulation of the host response, either through bacterial modulation, level 1, or through host characteristics as through the immunity and genetics, level 2, and then level 3, the environment. So in periodontitis, there's the role of bacteria. Now, some people have regarded periodontitis as chronic infections. That's the way Carranza puts it. It calls them chronic infections. I don't particularly agree with that. Some other people feel that periodontitis is primarily an inflammatory disease. According to Eckstein, he believes that, and I think to support that view. Now, of course, we know some bacteria play a very good role. The role of specific bacteria is still not very clear, but the old paradigm used to be that it used to be primarily bacterial. But the emerging thinking now is that it is primarily inflammatory. Now the question is this: which one comes first, the chicken or the egg? So this is there's a food for thought. Which one do you believe? Okay, talking about bacteria. Bacteria can cause disease, and for these bacteria to cause disease, those microorganisms must be able to colonize host periodontal tissues, evade host defenses, and eventually interact with host cells and cause host cell interaction. Those are some of the criteria. If you still remember the Cox criteria, and then the more robust Sokransky criteria, those are some of the ones that we are trying to bring in here. Now, there's a non-specific hypothesis, and there is a specific hypothesis. Both of these are being thrown out of the window, but the non-specific hypothesis seems to hold a little more now, which means we believe that all plaque is harmful. So once you remove the plaque, you are fine, right? But there are some people also believe in the specific plaque hypothesis, saying that just a few organisms, a few selected organisms are the ones causing the destruction. This is not believed anymore. People believe that there are several organisms, hundreds of organisms within the mouth. Some of them that we didn't even know so much about before, filifactor, and even certain viral entities that have been believed to be involved in the etiology of periodontitis. So the specific plaque hypothesis has actually been thrown overboard. Now, for this disease to occur, for periodontitis to occur, the agents, this bacteria, must be able to colonize the host. Before they can colonize host tissues, they must invade. Before they successfully invade, they must be able to evade host defenses or destroy host defenses. So let's take it again. The first thing is that they try to invade. When they invade, they try to evade or they dodge the host defenses. Now, if they encounter host defenses, they must be able to destroy host defenses. How do they do this? At times they do that through breaking down of antibodies that you produce. P. gingivalis can do that. P. intermedia can do that. Some of them will inhibit neutrophils. They inhibit phagocytosis and so on. Now, the leukotoxin that is produced by AA, that's the Aggregatibacter actinomycetum comitans, can do that, right? Some of them will inhibit lymphocyte function in order to, dodge the host defenses. AA can do that. F-nucleatum can do that. Some will induce apoptosis. So all those are the ways in which these organisms actually can cause problems. Because If they don't interfere with the host defenses will not just sit down there watching while the body gets destroyed. So they must be able to either evade or destroy host defenses. How do they do this? They use bacterial substances at times. Some of these substances would include enzymes. Those bacteria produce enzymes that are able to digest tissues, including intracellular matrix molecules. Some of the bacteria can produce metalloproteinases, serine proteinases. All these are basically enzymes. Elastases, collagenases, and the rest of them. And AA and P. gingivalis are very good at producing these collagenases. We also have keratinases, neuraminases, and the rest of them being produced. There are several destruction pathways that are possible, right? Either through the bacterial endotoxin release or through the action of neutrophils, monocytes, macrophages, and all these cells releasing interleukins, releasing cytokines, interleukin 1, TNF alpha, and prostaglandins. So those are the various destruction pathways. So those bacteria can release endotoxin that will lead to a string of other events. Remember that endotoxin also refers to a lipopolysaccharide. So remember that. So there's the direct pathway, there's the indirect pathway. So the direct pathway will involve the direct stimulation through the lipopolysaccharide, whereas the indirect pathway comes through the monocytes and the other cells. The final pathway is that the body is going to be stimulated to release these agents into the site where the destruction is going to take place. Eventually, there's going to be tissue destruction, and periodontitis ensues. Now, when we have those cytokines, the interleukin 1, TNF, prostaglandins, being derived from the host, now these substances are mediators of inflammation. Because they are derived from the host, we refer to them at times as host-derived mediators of inflammation. I told us last week that there are pro-inflammatory and anti-inflammatory interleukins, cytokines. Now, when we have the host mediators of inflammation, the HDM, host-derived mediators of inflammation, being upregulated, something happens. They upregulate the activities of other immune cells. They downregulate the activities of other ones, and they could also stimulate bone resorption. Right? So, what is happening? Bacterial invasion, signaling molecules, eventually acute inflammatory response, and then we now have the chronic inflammatory response, in which we have lymphocytes, macrophages, plasma cells playing a major role. Right? Now, resident neutrophils are mobilized in an attempt to contain the fight locally. I already discussed this with us last week, right? But let me move on. And if you see what is happening there in that in this little drawing here, bacterial products, acting on the host cells. In response to this, the host cells are going to be producing prostaglandins, cytokines, enzymes, and these enzymes are going to induce bone resorption, connective tissue breakdown. Eventually, we are going to have clinically pockets, clinical attachment loss, tooth mobility, tooth loss. So these are the clinical sequelae, which are the things we see clinically and interpret as periodontitis. Clinical features then, as a result of all this, would include the pocket formation, gingival bleeding, loose teeth, bone loss, and attachment loss, bone loss, and the rest of them. So, the etiology of periodontitis, we said dental plaque is the primary etiologic agent for chronic periodontitis or for periodontitis. There could be local factors and secondary factors. Now, the most of disease progression, usually there could be progressive loss random burst or multiple bursts, as indicated there in the slide. Well, in the past, we emphasized so much about gram-negative organisms, but now we know that gram-positive organisms are equally important. The classification has changed, but the controversies remain. Now, biomarkers are gaining prominence in the diagnosis and assessment of periodontitis. So, very quickly, well, now that we have periodontitis, there's going to be a periodontal pocket. We need to look at several aspects of this pocket. The morphology of the pocket, which could be gingival or periodontal. Relation of the pocket to the crestal bone. It could be supra-bony or infra-bony. In terms of surfaces, pocket could be simple, compact, or complex. Pocket could be active or passive. Now, the pocket that is supra-bony is a false pocket. Supracrestal, the crestal, talking about the alveolar crest. The pattern of bone loss normally is horizontal. Now, for the true pocket, that is the infrabony or intrabony pocket, the bone loss is subcrestal, and it gives you a true periodontal pocket. The bone loss is vertical, and the transeptal fibers are arranged in an oblique fashion. Let me just mention something here about pockets and the walls, pocket walls. You hear, one pocket wall, 2 pocket wall, 3 pocket wall. If you look at that diagram in front of you now, the worst is the single wall pocket, which is the diagram 3. It means here you have lost the buccal wall, you have lost the lingual wall. Now the one that is next in prognosis, better in prognosis, is the 2-wall pocket. The distal wall is still there. The lingual wall is still there, but the buccal wall is lost. And the best prognosis is the 3-wall pocket. Now we have both the lingual, buccal, and distal wall still there. So when you hear those expressions, it's a single wall pocket and not the rest of them. That is what it's talking about. So a single wall pocket has the worst prognosis. That's what we need to remember from that. A single, look at that, talking about the complexity of pocket. Simple pocket has just one surface of exit. A compact pocket has 2 or more surfaces, that you can see on the picture on the right there. And then a complex pocket is spiral, kind of a dodgy pocket. The point of exit is different from the actual base of the pocket. Now, what are some of the signs and symptoms of periodontitis? Remember what the signs and symptoms are. Remember that you need to take history. Now, the history will give you the symptoms, and then when you examine, you get the signs. The history is important. Remember Scully's A to M. And you can form your own A to M. It could be Wato's A to M, Kainde's A to M, Afolabi's A to M, anybody's A to M. Just remember those. A could be anything associated with the airway. B could be something like blood dyscrasias. C could be cardiovascular issues. D could deal with drugs. E could be endocrine issues. F could be fits, fits or epilepsy. G could be gastrointestinal issues or genetic issues. H could be hematological issues. I will be related to infections. J will related to jaundice. K, kidney issues. L will relate to, just name it. So down to M. Those are just to remind you, especially our students, of the things you need to take in history. So relevant history in periodontitis when you are treating periodontal patients, And then the history must be a full history. And then also remember to take medication history, dental history, and assess oral hygiene practices and habits. The use of floss or toothpick, all those are important for you to elicit. Examination of the periodontium, full extraoral and intraoral examination, and then you assess and record both soft tissue pathologies and tooth wear lesions is important. You perform a full mouth periodontal chart a full mouth periodontal chart. A periodontal chart, I hope you have seen one. I'll post one on the page if you have not seen one by the time we finish, so you can look at it later. But when you are doing a full periodontal chart, you're going to assess the calculus, assess probing pocket depth, assess suppuration, assess mucogingival defects, assess bleeding on probing, and the rest of them. You assess all this, and then you assess recession, assess mobility, migration, oral hygiene. In assessing mobility, you are not going to do what you are seeing in front of you there. Don't use your finger. Rather, you are supposed to use two ends of an instrument, and you can see in the video, And then there are various grades that are being used for mobility: grade 1, grade 2, grade 3. Right? Now, when you are assessing mobility, there's the Miller's classification, class 1, class 2, class 3, depending on whether it is less than 1 mm, greater than 1 mm, or greater than 1 mm with vertical mobility. So that's class 2 and 3. And then when you're assessing this, you also assess migration and fremitors. Assessing fremitors, if you look at it there, we see that in the video. Fremitor is a more advanced form of mobility. Some people will say maybe the teeth will vibrate when you check, but just look at that video. You see the examination assessing fremitors. And they examine the gingivae. We've already had the lecture on gingivitis, looking at the shape, the texture, the color, the size, and the rest of them. Remember this picture? You can see so many things here in gingivitis. All those must be assessed and recorded. And then periodontal probing, you use just 20 grams probing force. If you put your pen on your nail bed, the tip of your pen, and apply a little pressure, you feel a bit of pressure but no pain. That's about 20 grams force. So that's why we say bleeding on gentle probing, not just bleeding on probing. Because your gums will bleed if it is bleeding on probing once there's adequate force. But for it to be the one we are referring to in Perio, it is actually bleeding on gentle probing. Now, the probes are important. There's the UNC 15 that you can see right in front of you there now. There's the Goldman Fox. It has the Williams markings. There's the color-coded Marquis probe. There's probing force indicator probe. We had this, and then there's the computer-assisted probe. We had this in the part 1 examination at the time, and residents said it was an ultrasonic scaler. So that's a computer-assisted probe, right? And that's a very popular Williams probe with the Williams markings, as you can see there: 1 to 3, 5, 7, and then 8 to 10, right? So you see how to use the periodontal probe there. And then you also have to evaluate mucogingival defects, like you can see there. And then there are periodontal investigations that will include radiographs, bite wings, OPG. Remember that bite wing is superior to the periapical, because the bite wing gives you a better representation, because the light is incident at roughly 90 degrees on the film, rather than when you're using the periapical and the patient is pressing it, it's incident at an angle, so it's not that accurate. We see more of this, the implication of this, in other lectures in the future. Nutritional status, very important. We've neglected nutrition in Perio for many years, but one of our senior registrars is looking at that for his part 2. We are looking at some calcium, we're looking at vitamin D, blood tests, and the rest of them. I'm talking about markers. Markers. We now have the facility, the capacity to measure MMP8, both qualitatively and quantitatively. We have the machine here now in our center. Then there's a PSR probe, periodontal screening and recording probe. This is just like the WHO probe. It's for quick recording. Having the probe 3.5, 5.5, just like the CPITM probe. It shares similarities with the CPITM probe, right? And then talking about attachment loss, clinical attachment loss. If you look at that picture, from A to B, that's from the margin of the gingiva to the depth of the pocket. That's the pocket depth. From B to C, that's from the margin of the gingiva to the simoentoenamel junction. That is the recession. And then for you to get the clinical attachment loss, it is from A to C, which is from the cement junction to the base of the pocket. Now, clinical attachment loss is the basis for severity. When we say periodontal status, we are referring to clinical attachment loss. That's why we say CPITN cannot assess clinical attachment loss, because it does not measure clinical attachment loss. Even with some of the modifications, it does not accurately measure clinical attachment loss. It's not for periodontal status. Now, when there is mild, moderate, or severe clinical attachment loss, we are referring to the figures there: 1 to 2, 3 to 4, or anything from 5 mm or greater. All right? Right. Clinical attachment loss, already we have dwelt on that. There are certain advances that are coming up: digital radiography, cone beam CT, immunodiagnostic techniques, pressure sensitive probes, automated probes, all those. Right? That we end this section on our Perio Masterclass. I will entertain questions when we meet tomorrow. Thank you very much, and have a pleasant night. Rest.